Welcome everyone to Webinar Wednesday. We are very excited to share our lunch hour with Dr. Lindsay Berkson, who will share her insight and expertise with us today. Dr. Berkson is a known thought leader in functional medicine with an emphasis on hormones, nutrition, and digestion. Dr. Berkson has been a distinguished scholar at an estrogen think tank from Tulane University, a best-selling author, such as the first gut, body, mind nutrition book titled Healthy Digestion in a Natural Way, and the breakthrough book on endocrine disrupting compounds titled Hormone Deception, and her other best-selling book called Sexy Brain. Dr. Berkson has taught relicensing seminars to professionals, as well as symposiums for the lay public for almost 4 decades. Thank you so much for being with us, Dr. Berkson, and please begin when you are ready.
Thank you so much for having me. If we look at what's going on with COVID, we realize that the world needs functional medicine practitioners. So I love this opportunity. We are going to be talking in a sneak peek about hormones in the gut because most people do not connect hormones and the gut together at all. You're going to learn that the gut makes hormones and is responsive to hormones all throughout the entire digestive tract. The liver, the pancreas, the gallbladder does not seem to have any receptors or even transmembranous receptor activity in the gallbladder. You're going to learn that estriol upregulates adhesive proteins where? Between enterocytes. So it has a lot to do with helping to control what we now call leaky gut, or if a patient has elevated zonulin, which disassembles the adhesive proteins between enterocytes. We're going to learn that, or take a sneak peek into testosterone strengthening the gut immunity. So if on a GI map or a diagnostic test, you see low secretory IgA, you can sense that they might be insufficient in testosterone, or if they're very elevated secretory IgA, usually there's inflammation and they might need more estriol replacement. I'm soon going to show you a video of a patient that I used estriol replacement for to help get rid of their ulcerative colitis. You're also going to learn progesterone. Did you realize this? Regulates adhesive proteins too, not just estriol. So estriol upregulates junctional adhesive molecule A, JAM-A, and progesterone upregulates adhesive protein occludin. So these are the sticky proteins that help keep our gut wall opening and closing in the right way. And you're going to learn about estrogen in the parietal cells and why they're important. So this is the little testimonial that I thought would be very helpful for you.
Hi, my name is Charles Attar, and I have a daughter who has ulcerative colitis, and it was been very serious for quite a while, and then it got really bad until finally her doctor told her basically the only thing they could do was to take out her colon. And of course, this was shocking. Just found out about Dr. Berkson, and I spoke to her about it, and I had my daughter go in to meet her, and she got put on a program, nutrition, hormone therapy, changed her diet completely. She had all sorts of testing done for her allergies, and all these things combined basically made for an incredible difference. Within a short time, she was able to feel much better. She had a colonoscopy within a short time. It was about 3 months, and the results were already substantial. And then after that, about 3 months later, she had another one, and her results were great. So basically, she went from terrible to fine, good, which is remarkable. In fact, the doctor was really quite surprised as well.
So what we're going to learn, that nature never does anything without a reason. And why would the very hormones that drive Homo sapiens, the human race, be pro-carcinogenic or non-healing? So basically, we have receptors all throughout the GI tract. We have receptors that require a ligand binding receptors. These take a little bit of time for the ligand, like estrogen, testosterone, progesterone, to nestle on in and send a genomic signaling to the gene. So it's genomic signaling. And then we have transmembranous receptors all throughout the gut wall. For example, we have oxytocin, and we've got a third estrogen receptor The ligand binding is ER alpha and ER beta, the main estrogen, well-known receptors. And then we've got a third estrogen receptor, a transmembranous, a 7 transmembrane, because it goes back and forth and back and forth. 7 is kind of a holy number. And it's called GPR estrogen. It has a lot to do with sensation. This is one of the reasons that women get a lot more irritable bowel syndrome, because they have a lot more activity or imbalance to the GPR transmembranous receptors in the gut wall. By the way, I tend to give a lot like a Jewish mother with too much food. So I am going to go through some slides a little faster, because I hope you go back through them to glean this information better. So estrogen receptors, if we're focusing on this at the moment, are expressed throughout the digestive tract. We have ER1, who I worked with Elwood Jensen, who discovered it, and we have ER beta 2, which is very, very critical in the gut. The minute ER beta signaling goes down in the gut, you get more polyps, and you get the potential of more tumors. It's very, as we're going to show, inverse relationship. And I worked with Yanaki Gustafson. I've got a picture with me and Yanaki later on. He discovered ER beta, and so did Ken Korak, and I interviewed him for Hormone Deception. So when you lose the signaling of ER beta, this is a sign of risk of colorectal cancer, and also a sign of how bad your cancer will be. We also have GPR, the third estrogen receptor. And by the way, there's about 12 to 14 estrogen receptors and counting, because it's the oldest hormone on the planet. But we don't yet know what those other receptors do. But boy, we know that there's a lot more information coming down the road. So the GPR has a lot to do with the nervous system in the gut. That's why it has a lot to do with sensation. So there's a widespread expression of all the sex steroid hormones and other hormones that are of the nuclear family, and hormones that even aren't of the nuclear family in the gastric and intestinal mucosa, particularly in the enterocytes, in the epithelium, and the microbiome. There is a huge crosstalk between hormones in the microbiome and the gut wall. And when you get paralyzed by glyphosate and other pesticides, that affects the crosstalk that's normally supposed to take. And regulatory roles of these hormones are very huge, but it's never paid attention. And I've started to really pay attention with my inflammatory bowel disease patients, as you just heard with Melissa's father. One of the big things that helped her was giving her estriol replacement, because we rebooted the estriol signaling in her gut wall. So we're going to go through a little bit more about talking about that. But data indicates that the loss of estrogen signaling is associated with increased adenomultiplicity. The loss of ER beta is increased with the incidence of polyps and colon tumors. So we need to keep this signaling going on to keep protecting the gut wall. That's one of the reasons that women start having an increased incidence of colorectal cancer after they go into menopause. But if we give HRT, we can keep this healthy signaling at the gut wall continuing. Now, ER alpha is present in all of these different tissues in the body and throughout the intestinal wall. ER beta is present throughout all these tissues of the body and throughout the intestinal wall. So GPR is markedly expressed all throughout the nervous system in the gut. So hormones have a lot to do with the gut. When you have gut patients, you want to consider hormone replacement and testing their hormones. And we want to consider prophylactically making sure that women stay on hormone replacement to keep them healthier. We're seeing this with COVID. Women get more incidence of COVID, but they have much less severity and fatality from COVID. Part of that is because the estrogen of signaling that goes to the gut, because most of your immune system lives in the gut. So estrogens upregulate adhesive proteins. We need adhesive proteins, gut wall open, close, enterocytes open, close, and we want them to close appropriately. Well, estrogens have a lot to do with it. That's why they're helpful with autoimmune diseases, because they help keep that gut wall closing when it should. They heal the gut after injuries. You're going to learn about estrogen's big role in mitochondria, which is the bomb in the parietal cell, which ain't get no respect. Like Rodney Dangerfield once said, the parietal cells ain't get no respect. So let's just take a look at the parietal cells. So this is from Tulane when I was working there. Some of the scientists were just taking a look at where do they have receptors, the proteins for the receptors, where do they express? So ER beta was in all of these different organs, but in the gut wall, and protects against leaky gut, and it's along the entire digestive tract. Estriol, the estrogen that specifically signals the second estrogen receptor, that's why it's called ER beta, is very important for gut wall health and integrity. ER alpha is also throughout the entire gut wall, the smooth muscle, and the parietal cell. So we're going to talk a little bit about the parietal cell because it's a big love of mine. When I was in practice in Palo Alto for many years, I had a Heidelberg gastric analysis machine, which is a functional test for parietal cell functionality. And I was able to really understand exactly how much replacement a patient should have. So the parietal cell depends on estrogen for its mitochondrial robustness. And it has aromatase enzymes to take testosterone and directly make estradiol right in the parietal cell. And that's one reason you want testosterone as part of a bioidentical hormone replacement, because you make your estrogen that you need in the parietal cell via aromatase activity from testosterone being present. So a lot of times gynecologists will say we don't need to give testosterone unless you're in a relationship and you want to feel sexy. There's so many things that testosterone does. I could give an entire several-hour talk on that, but it's needed in the parietal cell to make estradiol. And hormone replacement thus helps promote parietal cell robustness, but just be careful, because if you give excessive progesterone, it can act as an anti-acid and it can down-regulate parietal cell efficiency. So in my intake with patients, I always run an anti-gastric parietal cell antibody. You can do it with Quest, you can do it with LabCorp, but a fair amount of people have autoimmune issues with parietal cell functionality. I also run intrinsic cell antibody, but this is important to run. So the gastric parietal cells make enough estrogen via that testosterone, via aromatase going to estradiol, in amounts equal to ovarian production. This comes out of Japanese studies. This was mind-bending when I first heard this. And then the estrogen is shunted via the portal vein into the liver, where it supports P450 detox enzymes. And it's one of the reasons women not on hormone replacement, when they become menopausal, start having really poor detoxification systems. And it's another reason for why you should have HRT. And if the patient has fatty liver or gallbladder disease, this estrogen, instead of being shunted to the liver, which is already all filled up and there's a lot more turbidity of the cellular membranes, then it will go more systemic. So I always kind of check my signs if a patient might have fatty liver, besides, that huge gut that they might have, is if their HDLs are insufficient, because you make your high density lipoproteins in the gut. And so I look at that. And then I also take a look at their steroid hormones, because steroid hormones have so much to do to keep the liver and detoxification healthy. And most people aren't aware of this. So the parietal cells, though, are very dependent on mitochondria. In fact, the parietal cells have the highest volume per cell of mitochondria of any cell in the whole body. That's really incredible. I just added this. So they have 40 to 45% of a cell volume of a parietal cell is made up of mitochondria, which make energy, but we now know that they have executive functionality too. Well, cardiac tissue only has 35%. I just looked it up. Brain tissue only has about 4 to 5%. Human skeletal muscle, which has the most mitochondrial density of all mammalian mitochondria, is only 3 to 8%. So if nature prioritizes giving the most energy to a cell, it is important, because we know that it gets rid of pathogens when they come in. We know that it reduces many of the electrical valence of nutrients to their right electrical levels, where they'll be absorbed well. We know that it is the first domino in digestion. Once the parietal cells make stomach acid, then cholecystokinin is secreted, and then it informs the gallbladder to contract and the pancreas to start secreting. So it is the top of the heap to get digestion going. Why this has gotten out of trend in gastroenterology space, I don't know, but we should not get it out of trend. And when you come to the talk where it's a bigger talk, I'm going to talk to you about the do's and don'ts of hydrochloric acid replacement with that. So estrogen helps control this mitochondria. We've now discovered that estrogen wears 400 and still counting hats of job descriptions. And one of them is it reduces mitochondrial damage. So estrogen is important to maintain mitochondria. It's important for the detox system in the liver. And so it's an important thing to add to the toolbox for you to keep your patients healthy and well. And if they have liver disease, you really want to do a deeper dive even more. So of course, the basic estrogen receptors are alpha, beta, and GPR. These are the ligand binding genomic, and this is the transmembranous non-genomic. And it's really the ratio, the Goldilocks ratio between all of them to make sure that things are kept just right. So estrogen promotes parietal cell function. Who knew that? Estrogen promotes parietal cell population. Did you know that? I mean, how many parietal cells we have? And I'm going to give you a slide just next that explains that. It's involved in hepatic detoxification. And when it wanes, all of these systems wane. And who can help bridge this? The best healers that we have, compounding pharmacists. Where would we be without our compounding pharmacists? I'm going to be 73, and I've been on hormone replacement now for 20 plus years. And I'm telling you, I would not be the human being I am without our compounding pharmacists. So here are the villi and the enterocytes, and the sex steroid hormones help upregulate adhesive proteins between these enterocytes. Estriol regulates, as I said before, junctional adhesive molecule A. It's one of the most important. It's like a sticky piece of bubble gum that helps the enterocytes close after the proper nutritional substances or constituents have crossed the gut wall. Progesterone upregulates occludens, and testosterone, in particular of the androgens, gives stability to secretory immunoglobulin A. So I always run this on every single patient. So these sticky adhesive proteins, they're substantially helped by estriol. That's why Melissa, you first heard from Charles, her father. One of the very first things we did was give Melissa estriol replacement, even though she's 24 years old. Okay, so zonulin is a disassembling protein, and you always want to measure zonulin, and you can measure it in the serum or you can measure it in the stool, but the elevated zonulin tells you you need even more adhesive proteins because they're being disassembled, and then you want to figure out what the imbalance in the gut microbial life is that you have zonulin in excess. So estrogen also boosts NRF2 and boosts estrogen diversity. So when estrogen is on board, you have more diversity. When you age, we know you have a loss of microbial diversity, which then makes your immune system more vulnerable. We don't want to be walking around vulnerable, especially with the Delta virus around. So what does promote intestinal diversity? We think microbial diversity. We think it's food. Yes, it's food. We think prebiotics. Yes, it is. Probiotics kind of stabilize that milieu. They don't really change it, but estrogen replacement reboots microbial diversity. I don't know if you knew that. Zonulin versus Akkermansia muciniphila. This is zonulin. If you have low Akkermansia muciniphila, then you're going to have an elevated risk of more zonulin. So our planet is threatening our hormone signals and tissues that contain receptors. And if you'll notice that our receptors are very, very flexible. So here's an estrogen molecule, and it's nestled on into an estrogen receptor. And then helix 12 closes on top, and it shimmies in space, and it delivers its signal. But this is a very malleable entity. And that is why a lot of endocrine disrupting compounds can go into the receptor and then cause damage to it. We also know that plastics are the bomb. Plastics block estrogen. This is just one example, especially if the fetus is exposed and the egg and the sperm are exposed. So there's a call for green pregnancies here. But phthalate and bisphenol and of course, there's also pesticides and other things and metallo compounds. These tend to affect how the fetus, as it grows up, will utilize hormones at different tissue levels. So this one study happened to show that BPA in utero blocked the ability of the fetus to use estrogen as it grew at the lung level. And this is also true at other global tissue levels. So we now live in a toxic environment. That's one of my main books, Hormone Deception. And based on that book, I was invited to go to the Center for Bioenvironmental Research. We now know that many of our hormones are under attack, and we're seeing younger and younger men and women have less and less hormones. I worked with Lou Gillette, a biologist at the University of Florida, and he's famous for testifying in front of the Senate and saying, no man in this room is as much a man as his grandfather was, because we have less androgens. Well, androgens stabilize secretory IgA. You just learned that. And estrogen, for example, upregulates adhesive proteins that keep the gut from going leaky or inflamed. And we also have anti-progestins, and progesterone resistance is an entity that is a real entity that is occurring more and more because other chemicals are sitting on this receptor. This receptor is malleable. It's built to receive. Like a woman's body, it's built to receive, and it will take in all of these potential endocrine disrupting compounds. And depending on many different genetics of the patient, it'll be whether they have trouble or they don't have trouble. Harvard actually just published a paper where they gave estradiol patches that we normally give to menopausal women to girls 14 to 24 years old that excessively exercised and had body dysphoria and anxiety for a year. They had so low estrogen. And so many of our kids are over exercising. So many of our women, you're not valued unless you're stick thin or something like that. In our society, we're pretty veneer oriented. And so we're seeing younger women with less of the hormones that protect the gut. And we're seeing, of course, a rising epidemic of gut issues. And we've had the worst outcomes with COVID of most countries because of how we eat and what's going on with all of that. Heavy metals displace estrogen. They're metalloestrogens. So I now work 1 week a month at the Naples Center for Functional Medicine that Dr. David Perlmutter, who put gluten on the map, his article, Gluten Dementia, Is Gluten the Culprit, was the most read article in Medscape up to the time that it was published. I now run in the serum cadmium, arsenic, and lead because they all displace estrogen. So gut walls aren't going to work well. And that's just what they're being exposed to now. And then I might do a provocation urine test, or then I might do a hair analysis to find out what they were exposed to in the past. But most of the people come in eating lots of fish. And fish now, of course, contain microplastics, which displace estrogen. They contain flame retardants, which displace estrogen and make fat stem cells very nasty. So they're actually obesogenic in their actions. But it also is a competitive inhibitor. It pushes estrogen. Estrogen can't get into that receptor because that malleable receptor is now filled with cadmium, arsenic, or lead. So I run this on all my patients. It's become a big deal. Fish now contain lead, mercury, arsenic, and these all won't let estrogen signal to the gut wall. So it's part of my workup. During pregnancy, one of the ways we learned about estriol being so gut protective is that women during pregnancy tend to have remissions of autoimmune diseases. And the two hormones that are highest, the pregnancy hormones, are estriol and progesterone, progest to support pregnancy. So it's really important to take a look at this phenomena. During pregnancy, women with MS or rheumatoid arthritis or other, Wernicke's granulomatosis, whatever the autoimmune disease is, they tend to go into remission. And then within a few months, they tend to rebound and be worse than ever because these hormones are now down to normal levels. So that started making people taking a look at what was going on here. And it's probably at the gut wall because a lot of progesterone elevated protects the mom's gut from all these hormones, and it protects the fetal brain and gut. But they started to look at giving estriol for autoimmune diseases based on the pregnancy observations. And they began to see that pregnancy has an immunosuppressive effect on autoimmune diseases such as MS, psoriasis, thyroiditis, uveitis, rheumatoid arthritis, the list goes on. So emerging data indicates that estriol is potential immune modulatory, meaning it will help the gut wall, which then helps the issue of this patient that's just told all they need to do now is take medication for life and have the sense of learned helplessness. I like to get people over inflammatory bowel disease, over or reduce the flares of very severe MS, etc. So it's now being looked at to treat autoimmune diseases, inflammatory diseases. That's where I came up with the idea of using it in inflammatory bowel disease, ulcerative colitis, Crohn's disease, and I also consider recurrent diverticulitis. It is considered an inflammatory disease, and even neurodegenerative conditions. I have a patient that I've been giving estriol and testosterone and glutathione to when she had MS flares, and it would reduce the flares from a month to a day. So her internist at Baylor Scott and White in Dallas called me up and said, "This looks amazing. This looks amazing." So I taught them the protocol, and now Baylor Scott and White is considering, at least through this smart, agile thinking doc, open-minded doc, to try interventions of estriol and the other things that we do for autoimmune disease, which are low-dose naltrexone, high-dose fish oil, and of course, avoiding any foods that create an upregulation of inflammatory issues of the gut wall, which are gluten and any other foods that you identify as being reactive. So they even say in a lot of these studies, estriol is very mild. You can give it to men. So I've started to give estriol as a facial cream to men, and also sometimes progesterone. And we're using this a lot on men that have these same issues. It's not just a potential replacement or treatment for women. So this is one article that reviewed in Medline, 72 articles to take a look at how might we use estriol. But now you know the underlying mechanism. It's because estriol boosts ER beta in the gut wall. And it's said that we can use it for chronic autoimmune diseases as a therapeutic option, and neurodegenerative illnesses and gut diseases. So, and they also said in this article, this is one of the conclusions of the authors, and this was in menopause, it's since it's relatively weak estrogen, there's potential use for it with men in MS. So normally in the facial cream, depending on the weight of the gentleman, I'll recommend 5 to 9 milligrams for patients with these issues, and sometimes even prophylactically if they don't have these issues, but they have a history, that'll put it. Here's a pilot trial where they gave 10 non-pregnant women with MS estriol, and they had a drop in inflammatory lesions in the brain, but it all started with the gut. As you heal the gut wall, you know, in the embryo, the emerging fetal cells that are going to make up the gut and the brain are one integrative mass, and then they split in half, and half goes to the brain and half remains in the gut. And there is this constant throughout life gut brain crosstalk. And so what works with estriol in the brain, it works with estriol, as you just heard. I have one more video at the end. I don't know if we're going to have time for that. I'm going to go down a little bit more. Here's the study with ER beta upregulating junctional adhesive molecule A. That is a beautiful adhesive molecule you want working. What does it? Estriol. So should we use only estradiol for replacement and not estriol? Now, some of the speakers out there say you can morph estriol from estradiol, so why do you need to give it? But you don't know how much they're going to make, and you need a lot more in people who've had gut lesions, polyps, inflammation. You need more. So I don't depend on they're giving them estradiol and hoping and praying and getting down on my knees in a biblical position that their body will make estriol out of estradiol. But this is one of the reasons you want Biest when you do replacement. So these are all the summaries of what ER beta does. It repairs broken DNA fragments. It represses oncogenes. It tightens gut wall. It modulates ER alpha so you don't get excessive ER alpha signaling. It is the best friend of ER alpha. We used to think progesterone polices ER alpha, but ER beta, of course, also polices ER alpha. Here's the receptor again. It's down-regulated without giving hormones. So when a woman or a man becomes menopausal or antepausal, these receptors get quiet. they downregulate. If you can think of a little doggy putting his paws across his face, they downregulate. That's why when you first, if you're beyond the estrogen window of 10 years and you're offering replacement, I write about this in Safe Hormones, Smart Women, you want to have a you go slower than most. You start low and go slow of hormone replacement because there is a hyperreactivity of the downregulated receptors. I learned all this working with the scientists who discovered these receptors when I was a distinguished scholar at Tulane. So you go very, very slowly, but you don't want the receptors to be shut up because then you're riding blind and nude with the gut wall and all of its best health. But of course, the receptor functionality is where it's at. And the limitation of many doctors today, gynecologists and endocrinologists in particular, is they only run levels. And whether it's saliva, urine, or serum, the level of a hormone doesn't tell you the functionality of the receptors. I actually have a new line launching with Biotics coming out next week. We've been working on it for a few years. I designed Metagenics' first fem line for physicians in the 80s, and it's several generations down the road. But it's all about moving these competitive inhibitors off the receptors like metalloestrogens or pesticides or plastics, and then giving the specific. So when you eat and you digest well, this receptor has to be filled with a milieu of nutrients that allow the hormone to really bind. Zinc fingers and magnesium and iodine and vitamin A, which ain't get no respect. Hardly anybody thinks about vitamin A. They're all nestled in on this receptor. And if they're not available, then the hormone doesn't signal optimally. So there is a bigger tapestry, so to speak, of hormones. And this is a study that shows you that if you have someone with polyps, they need more estriol or the foods that also stimulate ER beta, which are soy. It's the number one isoflavone that stimulates ER beta. There is no debate anymore. The more soy isoflavones you consume, the less your incidence of all gynecologic hormonally driven cancers, but also milk thistle and resveratrol and a number of other herbs tend to bind to ER beta. But if you've got a patient with a lot of polyps, I don't even do the 80-20 or the 50-50. I go much higher. And in my inflammatory bowel disease patients, I go much higher. I don't use those ratios that were used for healthy, normal people. I use more of a protocol, a more intensive protocol. And this is one patient, 48 patients affected by long-lasting pancolitis. And they took a look, and the ones that were worse had less ER beta. So I have a video at the bottom here of a patient who had pancolitis, then a colectomy. And before that, she had 20 diarrhea movements a day. And after the surgery, she had 10. She couldn't work. She couldn't hang out with her kids. We gave her estriol. We gave her low-dose naltrexone. We gave her high-dose fish oil. We identified and had her avoid many of the other reactive foods. And for the first time ever in over 20 years, when she got a colonoscopy, she looked like she never had any disease. And all of this happens fast. When you get the right treatment for these very ill patients, as you heard from Charles with Melissa, I always do a colonoscopy in 3 months. And if it's not going my way, I'm going to send them back to the Austin Regional Gastroenterologist, but do 1 to 3 months and 1 to 6 months to know what you're doing. And so ER beta is a big deal. We first learned about estriol. I see we're getting tight on time through looking at experimental conditions of MS, and they would create MS in animals and then give them estriol, and they were able to reduce the brain lesions or even the expression of it. So here's this paper for you, and they all often in the articles, they give estriol and testosterone, because testosterone stabilizes secretory immune globulin A, and estriol stabilizes those adhesive proteins, and also a little dash of estradiol, because then it helps the parietal cells, which you've just learned, which hardly anybody knows about. These are a few studies of pregnancy in estriol, and women who have ulcerative colitis, they have less estriol during their pregnancy, and their babies are born with less estriol, with more vulnerability to go on as they grow up to have more gut issues. And the less estriol they have, the babies were found to have higher cortisol, because it's a stress on the body not to have enough of the sex steroid hormones that drive humanity. the body wants them. And that's one of the reasons we get so ill so fast as we become menopausal or andropausal, because we start to become so stressed and so pro-inflammatory because we no longer have the sex steroid hormones on board. And this is the study that shows if you're born by C-section, you have a lot less estriol, and then the baby has a lot less estriol and a lot more cortisol, and the baby is already born in a pro-sympathetic state with a vulnerability as they age, depending on their lifestyle and choices, to have more problems with their gut. And an article came out this morning that 2/3 of our children and teens are eating ultra processed foods. I have a neighbor with a child that's 12 that has the worst case of brittle diabetes ever that Dell Pediatric Hospital has ever seen. And they've never spoken to them about diet. So the reason that I'm talking to you today is because I wrote one of the breakthrough books on endocrine disruption. And then I got invited to be a distinguished hormone scholar at the Center for Bioenvironmental Medicine, where I became best friends for life with William Toscano, who just retired from being the dean of the School of Public Health, and with John McLaughlin, who was the director and the brainchild of the CBR, who is considered the world's expert on estrogen. Here's Elwood Jensen, who discovered the first receptor, and his wife was a cabaret singer. So we rented a smoke-free cabaret in New Orleans, where Tulane is, and we put on a whole entire evening of hip hop and all kinds of stuff. We had all the hormone scientists that really made our understanding. We had the Kazanellenbogans, John and Benita, that have created all of the profiling for breast cancer patients. So she and I put on a big party for all these guys. Here's Yanaki that discovered the second receptor. And if I've summarized why, so in December 19th, 2019, in San Antonio, they have a yearly breast cancer symposium. So in December 2019, they had a 19-year reanalysis of the Women's Health Initiative. And they had 12 prestigious cancer institutions like Fred Hutchinson Research Center and Stanford and Harvard. And they said, we have reanalyzed the Women's Health Initiative, and it was wrong. And estrogen reduces the incidence of breast cancer, the case incidence, by 23%. And if a woman's even on estrogen for a short period of time, but then gets breast cancer over the next 19 years, she has a 44% reduction in fatality. Nothing's ever done that. So we're seeing that estrogen is being vindicated. And now we see that it has a role in the gut. So if you want this for free, you can go to drlindseyberkson.com/estrogen-vindicated-hold-/, and you can have this whole article that I sell on my website for free, because I want everybody to know this. And I have a membership where we talk about stuff like this, because I've been studying all of this for years and years, and I was a DES daughter and had breast cancer almost 30 years ago. So I've been ruined by hormones and saved by hormones. So let's go to, and here is, do we have time? I'm just going to play this next one. This is Carrie, and she had pancolitis and then a colectomy, and she's the one that's continued, instead of having 20 diarrhea bouts a day, she went down to 7 but couldn't work. And she came in, and she was in her early 40s. And we treated her again with that protocol that I just mentioned, along with stomach acid replacement, because her parietal cells were non-functional. And this is the video of Carrie. They've both allowed these to be played for your learning.
My name is Carrie Riegert, and I was diagnosed with ulcerative colitis 17 years ago. And I had my colon removed about 15 years ago. I met Dr. Berkson about 6 months ago, and since then my whole life has changed. I have more energy. I'm able to do more with my kids. I am basically a new person. And if there was one thing I would want people to know, is that if I knew how important nutrition was to health and healing, I would have done it a long time ago. So I think the most exciting part was being able to go to my colorectal doctor, and he scopes me every single year to look for changes in my colon and colorectal cancer. And he was shocked to see that I don't have any signs of colitis at all. It doesn't even look like I ever had it. So that was really exciting. And my regular doctor does a physical every year, and every year I have to have goals to, get healthier and to exercise more and stuff like that. And they told me that whatever I'm doing, to keep doing it, because I don't need any goals this year. I'm in perfect health. So in a short period of time, I've done some pretty amazing things.
So Carrie was on about 9 meds, and she got off all those meds in a month. Melissa was on 14 meds, very high dose of prednisone, huge flares, and she got off all of that in a month. The big shockaroo is when you do a protocol, especially adding estriol to reboost adhesive proteins and testosterone, the results, the improvements are fast. And in both cases, their post colonoscopies looked like they never had disease. So I just have to share this information and scream it from the mountaintops because it's so important. And I think we're going to end this and go to questions. Let's stop. We don't want to have that play. So now we're going to stop share and go to the questions over here. Can you outline normal values? Well, that's a question that everybody always asks. And so what are you looking at? Are you looking at serum? Are you looking at urine? I really try, if you're looking at serum, and I don't really go exactly by values, because what you're wanting to do is use these as a therapeutic intervention. But in a menopausal woman, let's say we're looking at serum, I like to get the estradiol levels, and you can't really measure estriol really well. You're going to give estriol, but it doesn't show up in the serum, and it does show up in a 24-hour urine. So I tend to run 24-hour urines, but I like to see the serum estrogen be above 65. Most women feel better at that. I think the therapeutic dosage range can be very low in young women because hormones work in parts per billion and trillion in very tiny amounts. So what you use for intervention doesn't necessarily reflect what you're doing for regular HRT replacement. But on the average, I'm giving these women 1 to 1.5 milligrams of estriol, and there aren't going to be any levels in the serum that reflect that. What dose of Biest do you give? So I just said for Biest, I'm usually giving 1 point. So I'll start much lower and then I'll build up. I'll usually start at 1/3 of a milligram of estriol. And then depending on their body size and where they're at and how their menstruation is going, I might not put estradiol in, or I'll always measure first their testosterone to decide if I want to add some testosterone in. How do you monitor estriol? In this case, this is more therapeutic. So I'm giving this estriol as replacement and then doing a follow-up colonoscopy. So it doesn't really have to do with levels. Would you use the same protocol with a 20-year postmenopausal woman with fatty liver disease? So first, I would want to get rid of the fatty liver. That's really important because when you have fatty liver, you have insulin resistance, and then the insulin will go to all of the nuclear family can sit on each other's receptors. So there's a lot of promiscuity and slutty behavior between all of these hormones. So if cortisol is too high, it can competitively inhibit sex steroid hormones. If insulin can't nestle on into the PPAR gamma receptor, it can also do that. So all the hormones function and dysfunction together. So when I do treat somebody, I also take a look at their insulin levels, their adrenal levels. I like to see their oxytocin levels because you've got oxytocin receptors in the gut. And I've been reversing Barrett's esophagus by using sex steroid hormones and also oxytocin with Mucilox. So I have some protocols that I do. And the only lab right now that runs oxytocin levels is Meridian. So I tend to run a 24-hour urine Meridian. Dosages for hormones in menopausal women are different than when you're doing inflammatory bowel disease or recurrent diverticulitis. But now that we've gotten the okay from the Women's Health Initiative 19-year reanalysis, I find that I start with hormones about 1/3 of a milligram of, let's say, estradiol. And then the dose range for menopausal women could be anywhere from 0.8 milligrams to 2.5 milligrams. But I have a friend, David Rosensweet, runs the menopause method. And when I had breast cancer, he was one of my doctors. So we've stayed close colleagues and friends. I'm going to see him this weekend in Nashville when I lecture for A4M and the North Carolina Functional Integrative Group. And he has one woman who was an internist, and her mother had horrific dementia. And this woman was already on estrogen, and her estradiol levels were 1.5 milligrams a day, but she was starting to lose words. So she just increased her dosage to the point where she no longer lost words. And now it's been 15 years later, and she is as sharp as a tack. And sorry, my phone just rang and I got distracted over there. And she had to go to such a high dose that she was menstruating. So sometimes you have an endpoint that's different than a replacement dosage. The endpoint being no more disease in the gut on a colonoscopy is different than the endpoint in a menopausal woman, where you're looking at how do you feel, how do you sleep, what's your energy, how do you poop, and the other thing that you want to take a look at with estrogen is their bone density, of course. But so the difference between intervention for a pathologic gut scenario is different than replacement in a menopausal or andropausal person. Can you repost or send us the link for the estrogen debunked article? Yes, let me do that right now and bring that up here. Oh, I guess I can't. I'll have to do it at the end. I'll do it at the end because I can't do it and read the notes. So I will. So thank you. It's a great question. Is there any therapy for progesterone resistance, and how do you need progesterone? And do you, oh God, this is a great question. So the thought, if you don't have a uterus, oh my God, then you don't need progesterone because you think progesterone only has one job, which is to oppose ER alpha growth signals at the uterine lining, which is nuts because progesterone has receptor sites on immune cells, on Treg cells, all throughout the nervous system, all throughout the brain. Progesterone is a bomb. I'm going to be talking for 2 hours on that this weekend at A4M's brand new 1B endocrinology module, which a number of my cronies from Tulane have kindly consented, like Ken Koresh, who helped co-discover ER beta. He's going to do the opening, and then I'm going to be lecturing after that. So progesterone is important in both men and women. It is important for nervous system. We know one of its metabolites, pregnenolone, has a lot to do with pain. The VA just came out with a study where they took almost 500 veterans from Afghanistan who all wanted to be on opioids, and we know the opioid crisis. So they gave them 500 milligrams of pregnenolone, and they had like a shocking relief of pain using pregnenolone because there's a lot to do with hormones, and they're anti-inflammatory and they're analgesic. So to say that if you don't have a uterus, thank you for bringing that up, that you don't need progesterone replacement is a misunderstanding of what sex steroids do and of the power of the prescription and what you can do to help your patients. But I always, in my patients that are on hormones that do have a uterus, that this is another reason that question is so great, is that you really want to make sure that the progesterone is opposed. So I like to do a vaginal ultrasound as soon as I've had, it can be a journey for some women to get to the right dose. Not all, but some women take 9 to 10 months to a year to get the optimal dose because you're starting low and going slow. Once we get the optimal dose for a few months, I want to do a vaginal ultrasound and make sure the endometrial stripe is 5 millimeters or less. And if it's not, the first thing I do is give a lot more progesterone. Of course, depending on how thick it is, they might need a D&C, but that is the bomb. You really need to know. And what we've discovered is you can have thickening, even hyperplasia with no spotting. So I go into this in depth, by the way, this weekend for A4M, because I love A4M, that they allow these you get in on people who are using all of this and how to help you with your patients. If someone has estrogen dominance based on the equation, now mind you, estrogen dominance is a really terrible term. I hate it, because we're now learning the importance of estrogen, and it's all about balance. And there's the good estrogen dominance, which is estrogen receptor beta. You want estrogen receptor beta. I was at a conference at Tulane and Yanaki was there. He discovered ER beta. And I said, Yanaki, I've come up with the term the good estrogen dominance because we want ER beta, especially all throughout the intestinal tract. And he said in his Swedish accent, ER beta? I wish I would have come up with that term myself. I would have trademarked it anyway. So there, that term irks me because we do want a lot of ER beta, and we almost come to vilify estrogen, especially with that term, the bad estrogen dominance. But if someone has estrogen dominance, okay, based on, and it's not your fault, it's the cultural fear that estrogen does all these bad things. That's why we're having talks like this. Based on the equation, but has leaky gut, is there a specific test you would suggest before giving them some kind of, well, we're talking about estriol. So estriol is not the growth signal. You're talking about excessive ER alpha signaling that gives you full breasts and bloat and gain weight and kind of foggy head. That's excessive ER alpha, which you want to police with all the other hormones, because hormones are a family that function and dysfunction together. So yes, I would still use estriol, because what you're talking about is ER alpha signaling, not ER beta signaling. Let's see. Please share your protocol for progesterone resistance. It's just, so the term progesterone resistance came from a study. If you go to PubMed and .gov and put in progesterone resistance and breast cancer, it'll pop right up. And they took, I think, about 25 breast cancer patients, and they looked at 2 endpoints of progesterone. They looked at breast temperature, and I guess they looked at serum levels of progesterone. I can't remember if that was the second one. And these women all were breast cancer survivors, and they were compared to a matched cohort of women who were not. And they saw that women who were breast cancer survivors didn't have an increased temperature in their breasts, because progesterone does increase temperature. And by the way, anxiety is a really big symptom of progesterone. It's an anti-anxiety hormone, because in the corpus luteum, where a lot of it is produced, but it's also produced in the brain. It's produced intrachronologically throughout the body. So it's not just produced in the corpus luteum, but at the same time, oxytocin is produced. So all throughout its life, oxytocin and progesterone have a very intimate action. And if not enough progesterone is being made, not enough oxytocin is also being made. So anxiety and, not feeling right in your body is a big symptom of not having enough progesterone. But when you have progesterone resistance, you just have to give higher dosages. So there's some women that need higher dosages. If we look at Katarina Dalton, she was the English physician that put premenstrual syndrome, the term, on the map. She's now dead, but if you go into PubMed.gov, she's got about 55 articles. And she was a forensic testifier for women that were being accused of murdering their husband or their babies by shaking their babies. And these were women that she had discerned really had severe mood dysregulation because of progesterone insufficiency in the premenstruum. So she came up with the term premenstrual syndrome, and she treated it with suppositories that go from 400 milligrams, because that's about what a woman makes every day during a normal pregnancy, to 900 milligrams, and there were no adverse effects. So the typical premenstrual woman makes 20 milligrams, and Katherine Dalton worked for years, decades, giving women up to 900 milligrams. So we've got this vast spectrum of potential dosage of what will be helpful, but you have to give more progesterone than the average bear, and to the point that the symptoms that you identify as being progesterone insufficiency or resistant, and they're often anxiety, don't feel right, spotting, the length of the periods are going up and down and not working really well, fibroids, vaginal vault, uterine polyps, and things like that. Overgrowth, because growth out of control is a suggestion that ER alpha signaling and progesterone signaling aren't in balance. I hope that answer. Biased is, it depends on how you're delivering bias. The question is, do you give bias twice a day? If I give bias as a topical, I give it once a day, and then you give it in a large amount of cream. You have them rub it in an area with fat under the skin for at least a minute, and you give it once a day. But if I give it vaginally, and there's all kinds of circumstances that I now like to give it vaginally, especially the Finnish study that was published in ACOG, was the most major study ever done. I write about it in Safe Hormones, Smart Women. For a woman's PhD, she took a look at all. So in Finland, when a woman becomes menopausal, they just give her hormones. She gets a choice of whatever she wants, because they've seen that their healthcare system doesn't topple and a woman stays healthier longer if she's on hormones. So they give it for free, whatever, any way the woman wants it. And then they have breast cancer registries. They've got heart adverse cardiovascular event registries, they've got death registries. They're a socialized country and they've been assessing very meticulously this data. So this woman for her PhD took a look at about 120,000 women over 14 years, which way they took hormone replacement in, and when they ended up in these registries. This is one of the most significant epidemiologic studies ever done. In fact, I sent the study to Jonathan Wright, who has been my mentor. Alan Gaby and I were students, and we did a rotation in integrative medicine with Dr. Wright in 1977. He fixed us up on a date, and he was hoping we were a match made in heaven. And we've all known each other and been hanging out and been dear friends ever since. So I sent this to Jonathan and I said, look at this. Women who took hormones vaginally never had any increased incidence of adverse events. So I'm going to start recommending vaginal. And this is before we had the 19-year reanalysis. So Jonathan started using all of his hormone replacement vaginally. And I have noticed that some women do a lot better if you divide vaginal doses up into twice a day. But I look and see how the woman does. If she has breast tenderness or how she's feeling, I go so much by how someone's feeling, because the level of hormones isn't the whole picture. What we're learning now is a lot of hormones are made peripherally, they act peripherally, and then they're degraded peripherally. So there's a huge amount of hormonal activity that goes on in peripheral tissue, like your coronary arteries, for example, or in your kidney, even, for example. I worked in a dialysis center for 10 years, so renal health is one of my loves. And so none of that shows up in blood, urine, or saliva. So we have like this whole space of hormone activity that we don't know yet how to assess, but in academia, they can assess it, but in the clinical trenches yet, we don't have the study. So how somebody feels trumps everything. It trumps the lab, it trumps everything, and it directs my traffic to try and keep the Titanic veering away from the iceberg, so to speak. How long do you keep the ester LMT going for inflammatory bowel disease? Well, I wait until we get a really healthy colonoscopy, and usually about 6 months after that, and then I'll start lowering the dose. But if anything, and I want them to be monitored by colonoscopies, if any symptoms start coming back up, I'll keep them on it. We learned from that Harvard study, given estradiol patches to 14 to 24-year-old girls, and the toxic world that doesn't allow most of the younger people to get the hormone signals they should, especially to areas like the gut, that they often need it. We're going to start seeing replacement in younger and younger people because of so much competitive inhibition by endocrine disrupting pollutants and metalloestrogens and things like that. So I go by the patient and I go by the colonoscopy or the imaging. I try and get as much imaging whichever way I can, and pre and post gut tests. And of course, your gut starts in your mouth and your nose. 50% of colorectal cancers have, for example, adverse pathogenic fusiform bacteria in them. So I try and look when someone's got an issue, a serious issue with one segment of the gut, I try and look at the entire system that all crosstalks, because all biomes crosstalk together. Progesterone I love this question. Thank you. Progesterone sensitivity as in headache and skin rashes. So progesterone you could be reactive to anything. You could be reactive to hormones. And we know that there's many articles in peer review about progesterone-induced dermatitis. People get rashes from progesterone. So what I do is I desensitize. And now I work a lot with breast cancer patients since I had breast cancer. And now I'm on hormones and I don't have breast cancer for 28 years. So I love working with breast cancer patients. I've been there, done that, and I like to help them out. And what were we just saying? I lost my train of thought when I started thinking of having breast cancer. That's funny. What was that, Lindsay? Let me go
Just
back.
give me one quick second here.
As soon as I was thinking I had breast cancer, my brain went there.
Progesterone sensitivity, as in headaches or skin rashes when they use it.
Thank you. So people can be reactive to hormones. So if they say to you that they've tried hormones before and they get headaches, they don't feel well, progesterone is often the most reactive. Or if they have hormonally driven illnesses. So if the man has prostate cancer or the woman has had uterine cancer or ovarian cancer or breast cancer, I will test all their hormones to see if they're reactive to them and desensitize them before I start them on the program. And there's two desensitization methods that I use. One is Jonathan Wright has this genius energetic machine whisperer, so to speak. So when he opened his clinic, I ran out there and met this gentleman and have him work on me. And they take a saliva sample and it's an energetic testing. And you can be on hormones when you're tested, but it's a 2-week protocol of sublingual drops to desensitize you. And I get a fair amount of women who can't handle progesterone. They get tested. If they're reactive, they get and I like to test all the hormones because sometimes one other hormone is futzing with the receptor of the hormone that appears to be reactive. And then they get treated for 2 weeks. And most of the time, then after that, they can handle progesterone with no issue. Dr. Brownstein, who's like a brother to me, David Brownstein in Michigan, he doesn't use that energetic evaluatory method for reactivity to hormones. He uses NAET, which is kind of like an acupressure system to figure out what you are reactive to and get your body over it. So that is one of the things is you can be, as shocking as it is, you could be reactive to spinach and chicken, not just wheat and soy, or you could be reactive to hormones. You could be reactive to humans. So we have to get bad humans out of your life. But anyway, so desensitization is where it's at for that kind of scenario. I have a whole protocol for endometriosis, the whole involved, but the problem is it's not FDA approved. So I wasn't able to speak on it at A4M, darn. But it's interesting. There's lots of theories of what really is the etiologic causes of endometriosis. And one of the theories is that it has progesterone resistance, so often giving progesterone to end women with history, because it's an immune system that doesn't think right. It's a lower IQ immune system, and it is a pro-inflammatory systemic condition. So even though they remove the endometrial implants surgically, the person still has kind of a dumb immune system that's pro-inflammatory. So you want to do all the things so you can take a look at it. But progesterone replacement has been helpful because progesterone resistance is part of the whole sequelae of, it's a very difficult, but I have very good luck with endometriosis, and a lot of women go on to get pregnant and not have to have surgeries anymore, pain anymore. And the other thing with endometriosis is that it is the one condition that looks like it's an excess of ER beta. And one of the theories, remember what causes endometriosis, everything is a bunch of theories, and it could be diverse in different women. So one of the theories is that it's an excess of ER beta. So they're one of the patients I'm not going to give estriol to, and I'm not going to give Bias to, unless I think for other reasons they need it or they had inflammatory bowel disease along with it. Do I use Prometrium? No, I don't like Prometrium, but some women love Prometrium and it is covered, it's reimbursed by insurance. So this is the deal that most doctors don't know. You now are going to know this. Hormones come in different grades depending on what you spend for them. It's kind of like buying organic food from your local grocery store versus Walmart versus Whole Foods. So at Whole Foods, they've got, or versus a farmer's market locally where the people just pulled the vegetables out and came on that Saturday morning to sell them to you. They're all organic vegetables, but testing has now shown that as you go down in expense, with farmer's market being at the top and Whole Foods next and the other places lower, they have less nutrients in them. They're different grades of food. I don't know if you knew that. Well, they're different grades of hormones, and that's based on their micronized size. So the more micronized they are, the better they're absorbed. Now, some women can absorb a bigger, larger, less micronized, and Prometrium is not so very micronized. It's a cheapo form of progesterone. Some women do great on it, some women don't. Of course, got peanut oil, and a study came out just last week. So in my membership, every day I'm reading the literature for 2 hours. I've done this for the past 40 some years and I love it. And I post all this information. So in my membership group, I posted a study that just came out that women who have breast cancer who consume peanuts have a higher incidence of metastasis because of a number of underlying mechanisms. So there's So peanuts have some good things about them, and their skins are kind of like grape. They have a lot of resveratrol, but they got a lot of potential, aflatoxin. And if they can make METs worse in a cancer patient, I'm not going to want to give progesterone to a woman that's got peanut oil in it. So that was a new article. And if you were in my membership, you learn about that. Let's see. Do you give DIM when you give estrogen? Not unless the woman needs it. There's so many supplements and people come in with these huge bags. And I think that's a stress on the esophagus and it's a stress on the liver and the kidney. So I try and hone in. And in my new products that clean off the receptors and balance hormones, I've got small amounts of things that act like DIM so that you don't have to worry about that. But maybe if the person has breast tenderness and estrogen, the parent hormones go to catechol-estrogens. And if there's 4 series, which are the more DNA damaging series, then I might give DIM and resveratrol because those are known to help balance out the ratio of the catechol-estrogens, the 2 series to the 4 series to the 16 series. We're kind of going into other arenas here, but let's see. I have a client who had a total hysterectomy. I don't know her age though. And she is having misinformation saying from her OB that she should only use progesterone. Another nurse practitioner that suggests to her that she should only do. So you've just learned to not add all the hormones in the mix is ridiculous. They all have an important role, but most doctors don't know that. So they say comments like this. And women are constantly told, okay, you had uterine cancer, you're 35, we're going to give you a total hysterectomy, and you can never be on estrogen again. So in the next few years, what happens to her? She gains 30 pounds, she can't lose it, and she has brain fog, and she's starting to really become menopausal in her 30s. So are you going to let women not have hormones because they had one cancer event? Our understanding of hormones in cancer are really about to change. Please get that estrogen vindication. I'll put that article up here. We've kind of covered a lot of information. I hope that this is my passion. I was very ill when I was younger. I had multiple cancers. No one could understand why till I finally got my birth records and discovered I was a DES daughter. I couldn't have children, so my books are my children. So if you want to meet my kids and my family. And so then I had to hack my health out of the mountainside because I kept getting cancers and tumors and no one could help me. So now in my older age, I'm going to be 73 soon. I have the youth I was never able to have in my younger age. And hormone balancing is a big part of it. When people told me when I had breast cancer, I could never be on hormones again, which has turned out to be the wrong information, which made sense to me back then. So hormones have ruined me and saved me. And so I'm passionate about putting this information forward. And I hope that you felt that and got some benefit, got a bigger, plumpier tool bag. And I so appreciate A4M. I love A4M for the opportunity to share this information with you all. It means the world to me because when I've been so ill, there was nowhere for me to go. Even now, I could tell you story after story is just horrifying. And functional medicine doctors, we need you. So I hope I help you be a better functional medicine doctor with my own story and with what I've learned.